We are live, sir. Please start.
Good evening, everyone, and welcome back to day 2 of Hematology Updates from Research to Practice. To begin today's program, it's my privilege to invite Dr. Vritti Ma'am, Associate Professor and Head Department of Clinical Hematology, Cancer Care and Research Center, HIMS, Dehradun. Ma'am, can you please start?
Good evening, everyone. I welcome you all for the day two of the meeting, Hematology Updates. Today, we have esteemed faculty from the country, and they will be updating us about the latest updates in the ASH 2025 in the fields of myeloma, myeloproliferative neoplasms, CAR T cell therapy, and aplastic anemia. For the first session, I invite Dr. Aditya Jandial for ASH 2025 updates on multiple myeloma. Dr. Aditya is Assistant Professor in the Department of Clinical Hematology and Medical Oncology at the prestigious PGI Chandigarh. Dr. Aditya, I welcome you for the presentation. Over to Dr. Aditya.
Uh, am I audible?
Yes, sir, you are audible.
I'll share my screen. Are my slides visible now?
Yes, sir, dear.
Good evening, everyone. First of all, I would like to thank Dr. Abriti for giving me this opportunity to be part of this session today. And it is my pleasure to discuss the best abstracts from ASH 2025, which focused on multiple myeloma. So, to put things into perspective, we all know that as we look at the treatment paradigm of multiple myeloma, so we categorize these patients into stem cell eligible and stem cell transplant ineligible patients. And for patients who are transplant eligible, they receive initial induction followed by consolidation and maintenance. For patients who are transplant ineligible, they initially receive induction followed by continuous therapy. And in vast majority of the patients, we see that these patients do relapse at variable time periods after initial treatment. And what we have seen in the recent past is that the biggest change in the treatment of multiple myeloma that has happened is that the PFS has improved when we have used effective and more potent agents in the upfront treatment. And it was like 2 to 3 years PFS about 20 years ago. And we have now transformed multiple myeloma to a disease which has a PFS of about 12 to 10 to 12 years. This slide summarizes the data with the quadruplet regimens, and we know that quadruplet regimens lead to significant deepening in the response rates in newly diagnosed multiple myeloma. There is doubling of the MRD negativity rates, and there is meaningful improvement in the PFS when we use quadruplets in the treatment of multiple myeloma. In the same light, when we look at the single agent response rates with the anti-myeloma drugs, so we know that the proteasome inhibitors and IMiDs, they have modest anti-myeloma activity. The monoclonal antibodies, they significantly improve the myeloma response rates. But the game changers have been the CAR T cell therapy with overall response rates of around almost 100%. And in the recent past, we have seen that bispecific antibodies like teclistamab, talquetamab, elrentamab, they have also showed promising response rates in the setting of multiple myeloma. And this was the long-term data from the CARTITUDE-1 trial, which was presented at ASCO 2025, and it showed that about one-third of the patients were progression-free at the end of 5 years, and that led us to question that if we use these immunotherapeutic options, which are like classically or I would say conventionally used in the relapsed refractory setting, and if we use them in the earlier lines of therapy or in the frontline therapy, they might completely change the overall natural history of the disease and may have significant impact on the outcomes of these patients. We also know that there is significant treatment attrition in multiple myeloma. With each new line of therapy, there is loss of around 20 to 30% of the patients. And that's why we need to use our best regimen in the upfront setting and not save it for the last. And with this context, I would start with the key updates, and I will be focusing on key 5 abstracts. So the first one is the Majestic 3 trial, which used the combination of teclistamab and daratumumab in relapsed refractory multiple myeloma, and there was simultaneous publication in NEJM. So this was a phase 3 trial, which included relapsed refractory multiple myeloma patients with 1 to 3 prior lines of therapy, including a proteasome inhibitor and a lenalidomide. The patients were randomized to receive either Tec Dara or Dara Pom Dex or Dara Bortezomib Dex. The Teclistamab and Dara were given in a weekly schedule for the initial 2 months. For the and subsequently they were used in once in 2 week schedule and once a month beyond 6 months. The key exclusion criteria were prior BCMA-directed therapy, refractoriness to the anti-CD38 monoclonal antibodies, and the primary endpoint was progression-free survival, with key secondary endpoints with being overall response rate, MRD negativity, overall survival, and safety. If we look at the baseline characteristics, so the median age was 64 years. Around 35% of the patients had high-risk cytogenetics. The extramedullary disease was there in around 15% of the patients, and ISS3 was myeloma ISS3 was there in around 8% of the patients. So if we look at the primary endpoint, so the Tec-Dara combination led to significant improvement in progression-free survival. So as compared to around 30% PFS at the end of 3 years, the Tec-Dara led to 83% PFS at the end of 3 years, which led to a remarkable hazard ratio of 0.17. And in addition, there was plateauing of the curve after 6 months, and more than 90% of the patients remained progression-free who were progression-free at 6 months, sustained such a benefit at 3 years as well. So that signifies the durability of response with this combination. If we look at the results across the subgroups, so the superior PFS with Tec-Dara was consistent across all the subgroups, including the high-risk cytogenetics. In terms of treatment responses, so overall response rate was around 90% with Tec-Dara combination as compared to 75% with the control arm. And it was not just the overall response rate. If we look at the depth of the response, so around 80% of the patient had CR, with median time to first response being around 1 month and median time to first CR being around 7 months. So this combination demonstrated significantly higher ORR as well as CR rates versus Dara-Pomdex or Dara-BD combination. The MRD negativity in evaluable cases was around 90% with this combination, and that shows the depth of response with this combination. The increased depth of response translated into improvement in overall survival as compared to 65% with the control arm. The Tec-Dara combination led to 83% overall survival at 3 years. If we look at the overall safety, so as expected, the major non-hematological toxicity was in the form of cytopenias and infections. So the CRS rate was around 60% in the overall experimental arm, with the majority being grade 1 and grade 2. In fact, none of the patients had grade 3 or grade 4 CRS. If we look at the summary of the infections, so majority of the infections were in the form of upper respiratory tract infections, pneumonia, and COVID-19, which because this was study was conducted during the COVID era. And there was a modification in the treatment protocol with the inclusion of immunoglobulin replacement therapy, which was included from Feb 2023, and that led to significant reduction in the mortality, which was initially attributed to hypogammaglobulinemia. And if we look at the distribution of grade 3 or more infections over time, So maximum infections were there in the initial 6 months, where like the frequency of infections was higher in the Tec-Dara combination as compared to the control arm. But beyond 6 months, the infections, there was a reduction in the overall incidence of infections, and the proportion of patients developing infections were comparable between the two arms. And that was probably because these patients were receiving IVIG prophylaxis. The DARA, Tec-Dara, the combination led to the improvement in the myeloma control, and both these things have had a bearing on this outcome. So the key takeaways from this abstract that were first, with 3-year PFS and overall OS of around 85%, this combination is one of the most effective treatment options for DARA non-refractory multiple myeloma at first relapse. And significant risk of hypogammaglobulinemia and infections mandate IVIG as a prophylaxis as early as the first cycle. And there is need to determine if time-limited therapy, like somewhere like 12 months or 18 months, is more appropriate for infection control, quality of life, cost, and resistance to future therapy. Second abstract is a French study, TechLily trial, which is a phase 2 study focusing on Tec-Dara combination in newly diagnosed multiple myeloma patients. So it was a small study comprising of 37 patients in the Tec-Dara, receiving Tec-Dara as a frontline treatment. And the primary endpoint was the rate of VGPR or better after 4 cycles, and secondary endpoints were overall response rate, PFS, OS, and MRD negativity. If we look at the study's the baseline characteristics, the median age was around 73 years. So it included patients primarily who were transplant non-eligible. And among these patients, about 50% were either intermediate fit or frail. Uh, about 30% of the patients had high risk cytogenetic disease at baseline, and majority of the patients had no extramedullary disease at baseline. If we look at the primary endpoint, the VGPR rate after 4 cycles was 95. Overall response rate was around 95%, and the best response rate was 100% in this cohort. Among the MRD evaluable patients, 100% of the patients in the Tec-Dara arm were MRD negative. And because of high overall response rate and MRD negativity, the PFS curves were just flat at median follow-up of around 10 months. If we look at the safety profile, so as expected, again, the cytopenias were the main hematological adverse events, and infections in the form of upper respiratory tract infections, COVID-19, they were the major non-hematological adverse events. CRS and was there in around 60% of the patients, majority being grade 1 and grade 2, and ICANS was not seen in any patients. So this combination, at least in the trial control settings, was feasible, and the treatment discontinuation rate was just 3%. In addition, the investigators also shared the additional aspects about the infections in these patients. So as you can see, the immunoglobulin IgG level, there was the profound drop during the treatment course, and about 95% of the patients were on immunoglobulin prophylaxis, median cycle of initiation being cycle 1. In addition, about 8% of the patients had CMV reactivation. They did monitor CMV every 3 months, and the CD4 levels were profoundly low during the follow period. So key takeaways were with VGPR and MRD negativity rates of around 100%, Tec-Dara combination appear to be very effective options for elderly and frail treatment ineligible NDMM patients. The rates of hypogammaglobulinemia and infections are higher than the standard of care therapy, and hence need of IVIG prophylaxis as early as possible is required. This study challenges the future role of IMiDs and PI as well as transplant in the future years as far as the treatment of newly diagnosed multiple myeloma patients is concerned. However, we need to take into consideration the high risk of infections and profound immunosuppression happening with this combination. The next cohort, the next abstract is the Cartitude 4 study. There was an update on the standard risk multiple myeloma patients who were treated in this trial. So we all know that Cartitude 4 was focused on the use of cilta-cel in relapsed refractory multiple myeloma patients who had received 1 to 3 prior lines of therapy and those who were len refractory. So the patients were randomized to receive either a standard of care arm, which was darapom dex or pomalidomide bortezomib dex, as compared to cilta-cel. And about 420 patients were randomized to receive either of these therapies. 60 patients who had standard risk cytogenetics per protocol were analyzed as a part of this abstract, and the results were presented. So if we look at the baseline characteristics, so the median age was 61 years, somewhat similar to what was there in the Cartitude 1. Plasmacytomas were there in around 5% of the patients, and median prior lines of therapy were two. Uh, all patients were lenalidomide refractory, 15% were daratumumab refractory, and around 10% of the patients were triple class refractory. If we look at the overall response rate, so it was 100% in standard risk multiple myeloma, irrespective of whether they had or not 1Q abnormalities. If we look at the PFS and OS, so the PFS was slightly lower in patients who had 1Q abnormalities. So it was 70% versus 80% in the overall cohort. Um, there was no difference in the overall survival based on whether they had or not 1Q abnormalities. But this is the key finding from this trial. So when we look at the PFS at the end of 30-month landmark analysis, so the outcomes of the standard risk myeloma patients who were treated as a part of Cartitude 4 were significantly better as compared to those who were treated in Cartitude 1, which indirectly means that these patients benefit more when they are treated with cilta-cel in the earlier lines of therapy as compared to later lines of therapy, which indirectly suggests that the T cell health might be better, and overall the immune landscape is more favorable towards immunotherapy if that is used earlier. The overall survival was also higher in patients who were treated in the Cartitude 4. So these benefits came at the cost of adverse events, which were mainly in the form of infections. Around 29% of patients had grade 3, grade 4 infections. 74% had CRS, or less than 2% of the patients had ICANS, and 7% of the patients had cranial nerve palsies during the follow-up. And it was the overall safety profile was consistent with the overall study population. So if we look at the key takeaways, so with 2.5 years PFS and OS of around 80% in the standard risk patients, cilta-cel seems to be the most effective single one-time treatment option for relapsed refractory multiple myeloma at first relapse, with CRS, ICANS, and infections being more common. They were like transient and manageable in the controlled trial settings. Late onset motor and neurocognitive toxicities can be challenging to manage, and access to therapy can be a barrier. So, advantages of one-time treatment versus lifelong therapy is something that we should discuss with our patients. The next abstract is the update on Redirect 1 study, which focused on the extramedullary disease. There was simultaneous publication in NEJM. And we all know that extramedullary disease in multiple myeloma is associated with poor survival. And as compared to those patients who do not have extramedullary disease. So in Redirect 1, the teclistamab and talquetamab were used in once in 2 weeks scheduled for 6 cycles, followed by once in 4 weeks duration. And the eligibility criteria included triple class exposed relapsed refractory multiple myeloma, and it included two extramedullary disease patients defined as bone independent soft tissue plasmacytomas more than 2 centimeters in graded dimension. The primary endpoints were was overall response rate. The key secondary endpoints were duration of response, PFS, OS, and safety. And if we look at the baseline characteristics, All patients had extramedullary disease at baseline. Around 85% were triple class refractory, 35% were drug refractory, and around 83% were refractory to the last line of treatment. If we look at the responses, 80% patients showed response with around 50% patients showing CR. And the depth of response was also associated with increased durability. And the median duration of response at the end of around 17 months of follow-up was not reached. And if we look at these results, so they are in stark contrast to what we see with the conventional anti-myeloma regimens in these subgroup of patients. And that indirectly suggests that probably dual targeting with against BCMA as well as GPRC 5D is something that can lead to meaningful change in the natural history of these patients. So this slide suggests that irrespective of the anatomical location of extramedullary disease, the overall response rate was consistent, and that shows that indirectly reflects the biological plausibility, and rather, I would say the potential of this combination to change the natural history of extramedullary disease. The median progression-free survival was 15 months at the median follow-up of 17 months, and overall survival was the median OS was not reached. As expected, again, the side effect profile showed a combination of safety concerns regarding both teclistamab as well as talquetamab. So there were cytopenias in around 70% of patients had neutropenia. The infections, all grade infections were there in around 80% of the patients, 33% being grade 3 or grade 4. And as also expected, the talquetamab-related toxicities in the form of nail changes, epithelial mucocutaneous toxicities were also present. So the another aspect is that the new onset of key any grade adverse events were less common when these patients were transitioned to once in 4-week dosing. So the grade 3, grade 4 infection rate was 33%, which is consistent with the TEC monotherapy in the Majestic 1 trial. And the most common infections were upper respiratory tract infections, COVID-19, and pneumonia. So the key takeaways were that with overall response rate of 80%, CR of 53%, median duration of response of around 1.5 years, this TEC and TAL combination is most effective treatment options for relapsed refractory myeloma with extramedullary disease. The tumor debulking options like DCEP, VDPAs prior to initiation of combination therapy may help augment response to therapy, and EMD continues to be an area of unmet need and needs early intervention and novel combinations. The next abstract is the first in human phase 1 study of in vivo CAR T in relapsed refractory multiple myeloma from the Australian group. So this study, they actually used a novel lentiviral vector, which prevents uptake in the liver and other LDL expressing cells, and precisely targets the vector to the T cells with the help of a novel envelope. The abstract included the results pertaining to 4 patients, and all 4 patients showed response to in vivo CAR T, with 3 of them showing MRD negativity, and all these patients had sustained reduction in soluble free light chains, M spike, and soluble BCMA. So, and as compared to the conventional CAR T, the in vivo CAR T had minimal adverse events, mainly in the form of cytopenias, infusion-related reactions, which were manageable with the tocilizumab and steroids. And again, the anemia and thrombocytopenia, they were like transient. They were not troublesome. So I think this may probably the next game changer in the immunotherapy space, and we need to be I feel very excited about the future results from these studies. The last abstract is the update on the anito-cel, which is a new CAR T cell therapy in the domain of multiple myeloma. So this included relapsed refractory multiple myeloma patients who had received 3 or more prior lines of therapy, including an IMiD, PI, and an anti-CD38 monoclonal antibody. And the primary endpoint was overall response rate, and the key secondary endpoints were overall the stringent CR and CR rate, PFS, OS, and MRD negativity. Just a word about the anito-cell. So, what is so special about anito-cell is the D domain, which is like different from the conventional BCMA CAR Ts, the cilta-cell and the ID cell that we have. So instead of single chain variable fragment, which is used as binding domain, so D domain confers more structural stability, incites less initial inflammation, and renders more manufacturing reliability to anito-cell. There were 117 patients included in this study. Extramedullary disease was there in around 20% of the patients, and 40% had high risk cytogenetics. Uh, 87% were triple class refractory, 40% were Prenta refractory, and around 80% of the patients had previously undergone transplant. The overall response rate was 96% with stringent CR rate of 74%. The median PFS and OS was not reached in the study during the follow-up yet. And the 6 months and 12 months PFS were 93 and 82%. So the estimated PFS for this product is somewhere around 2 to 2.5 years, which is in congruence to the other CAR T cell products that we have. Interestingly, the MRD negativity rates overall was 95%. Median time to MRD negativity was 1 month, and MRD negativity at 10 days for 6 was there in around 80% of the patients. Most of the patients had no CRS or CRS that resolved within 10 days of anito-cell infusion. There was no new treatment-related or treatment-emergent deaths since previous report, and no secondary primary T-cell malignancies, and no noted delayed or non-ICANS neurotoxicities like Parkinsonism, cranial palsies, or immune effector cell-associated enterocolitis. So, as expected, the cytopenias were there in around 70% of the patients, and 25% of the patients had anemia and thrombocytopenia. Uh, the incidence of grade 3 or more infections was less than 5%, and hypogammaglobulinemia was there in around 43% of the patients. So the key takeaways are that the anito-cell is as effective as cilta-cell without delayed neurotoxicity, with an overall response rate of around 95%, MRD negativity 95%, and 24 months PFS of 60%. The anito-cell has the rapid and reliable manufacturing and may lead to administered inpatient given early onset of CRS, and needs longer follow-up and more patients to study late onset neurotoxicity. So I think what I reckon from the ASH 2025 is that the spotlight has very rapidly shifted to immunotherapy as a tool to achieve cure or long-term disease control in the space of multiple myeloma. And it is this space is rapidly changing, and let's be hopeful about possible cure in the coming years. Thank you. I will stop presenting, and I will be happy to take questions.
Thank you so much, Dr. Aditya. It is always great to hear from you, Dr. Aditya. So thank you for highlighting all the updates and your crisp pointing on the various immunotherapy bispecific agent combinations, then CAR T cell therapy. The session is open for questions. If any questions from the audience, you may raise your hand and ask questions. So, Dr. Aditya, so
Yeah.
do you have any experience related to the combination therapies, maybe in the form of clinical trials at your center?
We have not yet used this tech DARA combination yet. we have used teclistamab as I would say, as a tool to achieve response, followed by transplant in two of our patients recently who had extensive extramedullary disease and those who were refractory to DARA-VRD. So that is itself like we were pleasantly surprised by the depth of the response achieved in in the two patients that we recently treated. And with this Majestic 3 trial being there on the horizon, I would say this is going to probably like change how we treat these patients in future. And instead of waiting for like three or more lines of therapy, these immunotherapy options may be utilized earlier in the coming years.
And what were the challenges you faced with Teclista in your practice?
So Teclista, as highlighted in these abstracts, so these are mainly infections. We are using IVIG prophylaxis in all our patients. And as in contrast to what is there described in studies, so instead of once in 2 weeks or once in a week dosing, after initial cycle, we are just giving once in 4 weeks to almost all of our patients. And that may be like I would say an adaptation that lower middle income countries might have to do as far as use of these agents. That might not just decrease the like incidence of infections, might save cost. And we also have data from some of the real world cohorts from United States that there are a subgroup of patients who may be stopped teclistamab at maybe like 6 months or maybe 12 months, depending upon the response. So that might be something that might give them a drug holiday and might might be helpful, like as compared to like continuous therapy in these patients.
Thank you very much, Dr. Aditya. Points well taken.
Yeah.
Now I invite Dr. Fahima Hassan. She's Associate Professor at United Medicity, Prayagraj. Dr. Fahima was supposed to present yesterday, but because of some emergency, she was not able to uh, join yesterday. But thank you, Dr. Fahima, for sparing your time today. I welcome you for the session on Management of CLL ASH 2025 Outlook.
Am I audible?
Yeah, you're audible.
Yes. Hello, everyone. Okay, so I have 10 minutes to give the ASH 2025 summary on CLL, but I have restricted myself to newly diagnosed CLL because 10 minutes is too much. ASH 2025 was mostly about CLL this year. So we'll start with, I'm not able to navigate. Okay, we'll start with all the phase 3 trials currently we have in CLL. These are the array of phase 3 trials, upfront CLL treatment. And these are the ones which we had the data in 2025. Except two, all of them were presented in 2025 ASH, and these two were presented in 2024 ASH. So yes, we have a lot of options currently. So I have tried to stratify or color coded them. So these green ones are the ones with triplet therapy, Amplify and CLL 13. And if we see the duration, both of these are time limited as they are triplets. And now in the duration column, if you can see, these yellow ones are the continuous BTKI based therapy. And then we have the orange ones, which is time limited based on MRD and the continuous one. And the last two, the dark gray ones, pertobrutinib, will not be delving onto that study because Perto is just recently approved for relapse refractory CLL. And these are very new data on newly diagnosed CLL. So we'll not be touching on those. So I'll try to concentrate mostly on CLL 17, which is of very good relevance for us currently in deciding the therapy for newly diagnosed CLL. And we also have these orange coded in these trials, the orange coded ones, do not include TP53, which is one mutation. I don't know how much of us are doing IGHV also. Currently, I'm doing for everyone, but then it was pretty expensive on a private sector. But TP53, we are ensuring that all of our CLL patients are getting it done. None of these triplet included TP53. And also, even the Bruin data, CLL 313 did not include TP53 mutated CLLs. So CLL 17 is going to be the focus. So what it is, it talks about continuous BTK inhibitor versus time limited venetoclax based therapy. So venetoclax was combined with obinutuzumab or with ibrutinib. With obin, we gave up to 50, both were given up to 15 cycles. So the assessment was done until progressive disease. The primary endpoint was, as we expected, PFS. The secondary endpoints are ORR, CRI rates, and efficacy and safety. So the baseline characteristics was equally divided between all the three cohorts. The overall response rate was the similar or insignificant between all the three cohorts. As we can see, it was 84.2 for Ven plus Obinu, Ven plus Ibrutinib 88.5, and single agent Ibrutinib was 86. But if we see the complete response was as expected, more in the Ven arm with obinutuzumab. And if we see as again expected, undetectable MRD was seen in 73.3% in the VO column compared to the VI column, which only had 47.2, and none of the monotherapy patients had undetectable MRD. But however, the caveat here is MRD was not used in any delineation in this trial, and the median follow-up was for 34 months. As we can see, the PFS was not very different. The VO, VI, and ibrutinib arm had a 3-year PFS rate of 81 versus 79 versus again 81%. So this kind of establishes a superiority of time limited therapy. I'm pretty sure most of us were using acalabrutinib, are currently using acalabrutinib continuous therapy for most of our CLL, whether they are TP53, IGHV, irrespective of the IGHV or TP53 status, most of us. But then this kind of also gives us hope that even time limited therapy of VO and VI are also a very good choice in these patients. But and by based on IGHV status, remember we didn't use a TP53 status much to delineate here. The 3-year PFS survival was also similar amidst all these three cohorts. And if we see the outcome by fitness, the 3-year PFS was in 80% almost in VO versus 75% in Ven Ibru versus 70% in Ibrutinib. So, and as expected, the adverse effects, what we are more concentrating about with the ibrutinib cohort is our cardiac disorders. And as expected, we also had febrile neutropenia and neutropenia more common in the doublet compared to the singlets. And what did they conclude? That the fixed duration targeted therapy achieved non-inferior PFS versus continuous ibrutinib. It is also easier to counsel the patient to say 15 months of therapy here versus lifelong therapy in the BTKI monotherapy. And the safety findings were consistent with the established toxicity profiles of these agents. And investigators concluded that fixed duration treatment can be reasonably considered for patients with previously untreated CLL. But what is the problem? One of the major challenges is that it is only exploring the fixed duration regimens when we compare monotherapy with the doublets as well. So all patients get the same length of therapy regardless of their genetic markers or their attainment of MRD. Now we are talking about CLL MRD, and these were not used to determine the length of the therapy. So here comes the flare. So we'll go to the initial table where we were talking about flare study. It is again an BTKI with BCL2 inhibitor or ibrutinib monotherapy or conventional chemoimmunotherapy. And it is time limited based on MRD. So we are using MRD to decide the duration of treating these CLL patients in this trial. It's a UK based one. So we'll see how Flare was very adaptive and how we can actually adapt it into our routine. So initially they only included FCR versus ibrutinib with rituximab. Later they also had a phase 2 randomization of 17p deleted or T53 mutated with ibrutinib versus ibrutinib and venetoclax. And they found that the time to achieve peripheral blood MRD negativity for high risk diseases, what it was around 3 years. So they made use of this, and they tried to guide us based on this flare and even other trials which use MRD, that good risk or IGHV mutated CLL, we can try this 12 months fixed duration of BCL2 with CD20, or standard risk we have to give up to 2 to 3 years, and for high risk at least 2 to 3 years, followed and guided by peripheral blood MRD. So this is the takeaway right now based on MRD. If at all we are doing MRD in our clinical routine for high risk patients, we should not limit us to 12 to 2 years. We can use MRD, and that too peripheral blood MRD is a very good marker, non-invasive, and we can very well get a clue of how long to continue the limited BCL2 with BTK inhibitors. So now we'll also touch upon the doublets versus triplets. Of course, triplets had an impressive progression-free survival. We can see that AVO, Acala, Ven plus obinutuzumab was better than AV, was of course better than chemoimmunotherapy. This did not include the TP50 mutated CLLs. So what is the catch? If we look at the survival was very low for AVO, the triplet group. Na? So this is the caveat. When we compare, amplify, the overall survival was lesser for the triplet AVO. So this is why it is not a very good choice for us to give upfront triplet in patients with CLL. And we also had increased grade 3 neutropenia and infections. I know my time is up, but I just wanted to say this. Both of these Amplify and CLL13, all of these used triplets in treatment of upfront CLL, and we also found higher infection rates and higher degree of grade 3 neutropenia and also febrile neutropenia and higher degrees of treatment discontinuation in the triplet arm. So, and we also had a number of MRD driven studies. Again, Amplify again was MRD driven, CLL13, CLL14, FLARE, GLOW, and Sequoia. And peripheral blood MRD was proven as good as bone marrow MRD. But is it really important for us to guide via MRD? Is a question. Initially, we were under the impression by smaller trials that MRD means improved PFS and OS, but it does not actually reflect with the amplified data. In amplified data, Acala Ven had a superior 36-month PFS compared to chemoimmunotherapy, even though the FCR group had a better undetectable MRD. So it is not really translating into PFS or OS. So that is a take home. Thank you. Any doubts you can ask me. Yes, Avriti.
Thank you very much, Dr. Fahima, for this wonderful session.
Thank you.
Just a quick query. So, do
Yeah.
you practice MRD in your clinical
Not
practice?
yet, but I'm pretty excited, especially for the TP3 mutated CLLs. But not to, get the improved PFS. I'm not targeting for MRD negativity, but then just to, to guide on whether I'll go for time limited therapy for how long a duration. That would be the option I'll be
And have
going
you
for.
tried like
I haven't.
venetoclax,
I haven't yet. No, no.
rituxi, veneto
Yes,
combinations?
yes, of course. I have given
Because
rituximab with venetoclax. Yes.
obinutuzumab, I have not
Obinutuzumab,
tried
it's too
yet.
expensive. I'm just trying to counsel some patients to get into VO, but rituximab with venetoclax is easily
And
usable.
where does BR stand in your practice?
None, none. Given up
None.
2 years ago. Completely given up. And I'm also stopping this monotherapy with BTK inhibitors. I'm not pretty happy. So I think I'll be shifting more towards Ven-based.
Okay.
Okay, everything.
Anybody from the audience, if they have any queries, please you can open your mics and just ask. If not, thank you very much, Dr. Fahima,
Okay,
for
everything.
sparing
Thank you so much.
time.
Thanks for this opportunity. Bye-bye.
So now I welcome Dr. Rajiv Sandal. He is from Shimla, IGMC Shimla, Department of Clinical Hematology, and sir will be talking about the early use of denosumab in newly diagnosed multiple myeloma. I welcome you, sir.
Hello. Good evening, ma'am. So, am I audible?
Yeah, you're audible.
So, I'm sharing my screen. So, my screen is visible, ma'am. Ma'am, my screen is visible.
Yeah, it is visible.
Yes, sir. Yes, please.
So, thank you, ma'am, for giving me this opportunity to me. So, my topic is I will discuss about the use of denosumab in newly diagnosed multiple myeloma. So, we all know that bone disease are main criteria of the CRABs, and bone lesion and renal failure carry the greatest risk for the decreasing quantity and quality of the life of the patient in multiple myeloma, and these can lead to lifelong consequences for patient. So osteolytic lesions can be identified in 80% of patient at diagnosis, and these predispose patient to skeletal related events like bone pains, pathological fracture, vertebral collapse, and spinal cord compression. So, if we're talking about the bone targeting agents in bone metastasis, so we all know that it is in 1988 FDA approved pamidronate, which is biphosphonate for patient in breast cancer with bone metastasis. In 2002, zondonic acid is approved for multiple myeloma and bone insoluble malignancy with bone metastasis. In 2010, so FDA approved denosumab for solid malignancy, and in 2018 it is approved for multiple myeloma for prevention of SREs. So what is denosumab? So denosumab is a fully human monoclonal antibody of the IgG2 isotype that binds to rank ligand with high affinity and specificity. It prevents rank ligand from activating its receptor rank on the surface of osteoclast and their precursor. So we all know bone hemostasis is a balance between bone formation and bone resorption, and which is maintained by osteoblast and osteoclast. So what happened in the multiple myeloma? This, so in myeloma, multiple myeloma cell induce osteoblast to secrete ligands. So rank ligands bind to osteoclast and increase their proliferation. This lead to increased activity of osteoclasts and resorption of the bone. So balance is shifted toward the resorption of the bone, leading to osteolytic lesion. So, but denosumab target mainly it binds the rank ligand and prevent the activation of rank receptor on osteoclast. So, denosumab binding decrease the activity of osteoclasts, and it decrease the bone resorption. So, indication of denosumab, we all know that is it approved in osteoporosis and prevention of skeletal related events in patient with multiple myeloma and in patient with bone metastasis in solid tumors. It's also approved in giant cell tumor and treatment of hypercalcemia and malignancy. So doses, it is a subcutaneous injection, and in dose is 120 milligram every 4 weekly. In hypercalcemia, you can repeat the dose on day 8 and day 15 of the first month of therapy. So clinical evidence in malignancy. So it is the meta-analysis of three randomized trial published in 2012. So these are randomized double-blind activator controlled phase 3 trial, which compare the denosumab with zoledronic acid. Most of patients are solid malignancy, which is breast cancer, prostate cancer, and other solid tumors, and some patient of multiple myeloma. So patients have more than one radiological bone metastasis or bone lesion with ECOG of 0 to 2. Endpoint of these studies are time to first SRE, time to first and subsequent SRE, adverse events of drug, time to disease progression, and overall survival. So this is an integrated analysis of these three trial, which show that median time for first SRE is 27.7 months in denosumab arm as compared to 19.5 months in zoledronic arm. So this lead to reduce in the risk of first to study SRE by 17%, and it also lead to a reduce subsequent SRE risk by 18%. And this increased the median time to first on study skeletal related event by more than 8 months. Additionally, denosumab reduced the risk of first on study SRE as compared to zoledronic acid in patient with and without previous SRE at baseline. So, other points from this analysis of three randomized trial. So, disease progression and overall survival were similar in both arms. In contrast to zoledronic acid, denosumab did not require any monitoring and dose modification and withholding based on renal status, and was not associated with any acute phase reaction. Hypocalcemia is more common with denosumab, but osteonecrosis of jaw is similar. So, author concluded that denosumab was superior to zoledronic acid in preventing skeletal related event with favorable safety and convenience in patient with bone metastasis from advanced cancer. So, in multiple myeloma, this is a landmark trial which lead to approval of denosumab in multiple myeloma. It published in 2018. So, it is a international double-blind, double-dummy randomized control phase 3 study which conducted in 259 centers across the 29 countries. So, patients are randomized 1 to 1 arm denosumab versus zoledronic acid along with the investigator choice of anti-myeloma therapy. So primary endpoint of this study is non-inferiority for time to first skeletal later event and safety of drugs. So you can see this Kaplan-Meier curve which estimate the time to first skeletal lateral event. So denosumab was non-inferior. You can see from graph non-inferior to zoledronic acid in delaying the first SRE, with no superiority in median time to first SRE. So this is the post hoc analysis after 15 months. So we show that denosumab has superiority over zoledronic acid in delaying time to first SRE with a few events beyond 15 months, despite similar treatment exposure duration in two arms. So, if we see the overall survival and progression-free survival, so there is no overall survival benefit in both arms, but in progression-free survival, denosumab show a longer progression-free as compared to zoledronic acid with p-value of 0.036. Uh, if we see the safety concerns, so there is no additional safety concern with denosumab. Hypocalcemia is slightly more in denosumab, but grade 3 or 4 hypocalcemia is similar, and risk of jaw necrosis is also similar in both arms. So author concluded that denosumab was non-inferior to zoledronic acid in delaying the time to first skeletal related event following randomization. The result of overall survival are comparable between two arms. So this lead to approval of denosumab in multiple myeloma for prevention of a skeletal related event. So this is a subgroup analysis of previous trial I have discussed in Asian patient and published in 2020. So study design is similar. So in Asian subgroup patient, median progression-free survival is similar in both arms as you see from this graph. And if we see the safety concern in Asian patients, so 20% of patients have side effect in both arm, and grade 3 and 4 side effect are similar. And the author concluded that Asian subgroup results mirror the overall study, supporting denosumab as an effective alternative to zoledronic acid for newly diagnosed multiple myeloma. So this is another exploratory result of this trial I have discussed. So they do the ad hoc subgroup progression-free analysis. They divide patient in three groups: autologous stem cell transplant intent, renal on the basis of renal function, and on the basis of age. So in this analysis, So progression-free benefit of denosumab in autologous stem cell intent subgroup. So authors show that it have median progression-free survival of 46.1 months for denosumab group arm as compared to 35.7 months in zoledronate group. So patient which have which are eligible for autologous stem cell transplant, they have a median progression-free survival benefit with denosumab, and as compared to patient mm, which are not eligible for autologous stem cell transplant, their progression-free survival is similar in two arms. Or if we see the renal parameter, so author concluded that patient with creatinine clearance more than 60 ml per minute denosumab show progression free survival benefit as compared to zoledronic acid. But if we see the overall renal impact, the patient with impaired renal function had worse progression-free survival than those with creatinine clearance more than 60, irrespective of treatment. So, denosumab show one of the largest progression-free survival benefit in newly diagnosed patient, especially autologous stem cell intent patient, and which received PI-based triplet regimes. So this is another study which compared the safety and efficacy of denosumab in patient with multiple myeloma with severe renal impairment. That is GFR of less than 30. So it include 98 patient. 50% of patient are relapsed refractory multiple myeloma with median 5 prior lines of therapy. And baseline characteristic: all patient have bone disease. All relapsed refractory multiple myeloma patients received zoledronic acid previously, and 20% of patient on dialysis. So multiple myeloma related renal failure in 73% of patient, and 15% patient have hypercalcemia. So treatment in this 85% of patients received denosumab 120 milligram monthly, and 14% of patients receive 60 milligram monthly. They receive anti-myeloma therapy, BCD, and anti-CD38 based regime. So if we see the skeletal outcome, so no new skeletal related events occur during the follow-up with denosumab. So treatment discontinuation: 44.9% patient remain on denosumab, and main reason for discontinuation is a progression of disease or hypokalemia and death. So if we see the safety concern, so 52% of patient develop grade hypocalcemia. Most of patient have hypocalcemia of grade 1 or 2. Osteonecrosis is seen in 3% of patient. So author concluded that denosumab is effective and safe for multiple myeloma patient with severe renal impairment, provided that proactive measures are taken to mitigate hypocalcemia. So this is the other paper which show the effect of denosumab, which compare the effect of denosumab versus bisphosphonates in patient with hypercalcemia in multiple myeloma. So in this study, it is a retrospective analysis, and most of patient in denosumab group are relapsed refractory. Only 33% patient are newly diagnosed multiple myeloma as compared to 55% of patient in bisphosphonates group. So author concluded that most of patient median time to achieve remission, that is normal calcium, is 2 days as compared to 3 days in bisphosphonates group, and hypercalcemia relapse is less in denosumab group as compared to bisphosphonates group. So, what is about the recent guideline about the denosumab or or bone targeting agents? So, NCCN 2026 guideline show that all patients should be received bone targeting treatment, either bisphonate or denosumab, and duration of treatment is up to 2 years, and most of patient denosumab should be preferred in the patient with renal insufficiency and caution of risk of hypercalcemia. So, take home message is that skeleton related events with tumor have a significant patient and economic burden. Bisphosphonate and denosumab play a key role in management of multiple myeloma. Denosumab shall be preferred in patient with renal failure, and denosumab 120 milligram every 4 weekly subcutaneous is well tolerated. Skeleton related event prevention remains important despite new and effective anti-tumor therapies in multiple myeloma. Thanks.
Thank you so much, Dr. Rajiv. Uh, Now I welcome Dr. Naveen Vairamurthy, sir, consultant hematologist, DMT and cellular therapy from Mumbai for a session on CAR T cell therapy. Sir would be moderating the session.
And for the panelist, I would like to invite Dr. Pawan Kumar Singh, Group Director, Hematology, Oncology, and Bone Marrow Transplant, Yatharth Hospital, New Delhi, and Dr. Tejaswini Vaid, Consultant Department of Medical and Hemato-Oncology, Medanta Hospital, Noida, Dr. Sanjeev Kumar Sharma, Principal Director and Unit Head, Medical Oncology, BLK Max Hospital, Dr. Vishnu Sharma, Assistant Professor, Clinical Hematology, SMS Medical College and Hospital, Jaipur. And for the some emergency, Dr. Saurav Bhave is not able to join the session. Thank you.
Good evening, everyone. It is an honor to moderate this panel with such experienced faculty. And let me start with sharing my slides. Can you allow sharing slides, please?
So I request Dr. Rajiv sir to close his screen.
Okay.
Thank you, sir.
Is my screen visible now?
Yes.
Yes, it's
Yes.
visible.
Yes. Nice. Good evening, everyone. And we have roughly 30 minutes, and I'll move us through 15 discussion points, followed by two short cases. So the format I'll keep will be, I'll present a clinical question with the relevant data, and then I'll open it to the panel as a whole. So any of the faculty may share your experience and expert perspective. So after a couple of responses per point, we'll move to the next slide to keep the pace. So I'll start with foundational CAR-T landscape and then move into practical decision making. We have two cases to discuss. So let's begin. So I'll start with a simple but important question. So why CAR-T and why now? So just to anchor what we are seeing, according to Scholar One study, a first patient level analysis of outcomes with conventional subsequent line therapy for refractory DLBCL, the outcomes are still disappointing with an objective response rate of 26% and CR of only 7% and a median overall survival of roughly 6 months, and only about 20% of the patients were alive at 2 years. So this slide shows that standard salvage therapy in refractory DLBCL has low response and very short survival. Even with the transplant in CR2 or later, historical outcomes show 22 to 43% leukemia-free survival, depending on risk category and study. So this is the unmet need CAR-T is trying to address. So this algorithm shows current treatment paradigm for relapsed refractory DLBCL, where CAR-T has moved an earlier line for patients with primary refractory disease or relapse within 12 months with salvage therapy and autologous stem cell transplant as alternatives when immediate CAR-T is not feasible. So these recommendations align with latest NCCN guidelines, which favor earlier CAR-T placement and particularly in patients who have higher tumor bulk and aggressive tumor biology. So my question to the panel is, given this baseline, where do you place CAR-T in your real world pathway today? Straight after we see primary refractory or early relapse, or do you try a salvage therapy attempt first? And if it fails, then you choose CAR-T.
Uh, Hello. Yeah,
Yes, sir.
yeah, I'm Dr. Sanjeev from BLK. So thanks, Dr. Naveen, and thanks, organizer, for giving us this opportunity to be a part of this webinar. So what I am doing right now, actually, though we counsel for CAR T cell therapy, but what happens ultimately in real world is that most of the patients land up going for transplant as a first option, even if they relapse early. So CAR T cell therapy is definitely, we are counseling the patients accordingly, that if they are relapsing early within 12 months, CAR T therapy should be considered. But comparing and cost, logistics, and everything, patients actually they do tend to agree, but ultimately we have to transplant the patients who ultimately actually could not go for CAR T cell therapy. So that is what real situation we are having right now.
Okay, sir. Thank you, sir.
Yeah. And Dr. Pawan and others can also
Mm.
share their experience.
Yeah, hi, Pavan here from Yatharth Hospital. So, more or less, we try and stick to the protocol or the algorithm. So, patient who relapses early, and there is the Scholar One data clearly says that these are the patients who are not going to do better, even with the salvage therapy and autologous transplant. So, those patients relapsing early within 12 months, they ideally should be given upfront CAR T cell therapy, and later means relapses after 1 year they should be. But I agree with Dr. Sanjeev that in real world scenario it is not feasible for us, because if we compare the cost, it is compared to autologous transplant. I can say that in any private hospital it will be approximately 4 to 5 times more of CAR T cell therapy cost. So these are the means actual, but yes, ideally, as far as this algorithm is concerned, we try and stick to this algorithm.
Thank
I
you, sir.
I second Dr. Pawan and Dr. Sanjeev's opinion on this, that patients who relapse early or have refractory disease, uh, including the patients who relapse like within first 12 months, they're going to have chemo refractory disease. So perhaps upfront autologous transplant would not be the wisest option for them. We here, I'm working at Medanta Gurgaon. We offer CAR T cell therapy to whoever can afford it. However, if the relapse is beyond 12 months, the disease is chemosensitive, we prefer an autologous transplant because I feel like the approval of CAR Ts are based on the Western data, on the basis of axicell and lisocell. But what we give to the patients here is a different CAR T. And hence, in a chemosensitive disease, definitely I would prefer an autologous transplant. But in patients who relapse early, CAR T is the way to go.
Thank you. So it sounds more like that we have a consensus that early referral, if the disease is clearly refractory, and sometimes we modify it based on the context. So going to the next thing, when it comes to efficacy, when we review the literature, published data shows the CAR T cell does work in a meaningful proportion of patients refracted to previous lines of therapy. Based on the Zuma 1 and NEGM data and Indian phase 2 studies, we are seeing an overall response rate of 70 to 80 percentage in pivotal studies and CR rates of around 54 to 71 percentage, and a meaningful survival with median OS of around 25 months in the Indian B cell BNHL cohort. This establishes that responses can be deep and durable in a subset. Given this efficacy, the debate shifts from does CAR-T work to selection, timing, as well as managing toxicity. So my question to the panel would be, in your patient counseling, when you quote numbers regarding the response, what proportion do you describe as durable response or cure like versus good response versus, but usually temporary? Like how will we describe whether it is we go more towards a durable response or we go towards it's a temporary response, and how will we frame the realistic goal?
Yeah, so here again, actually, response criteria depends on which type of lymphoma, and particularly if we are talking about DLBCL, then what I think is at least 2 years patient should be in remission to call it, yeah, patient has some sort of remission. Though this NCCN says that if less than 1 year, then patient is considered as refractory to primary treatment. But that is one. And one more thing, that at least if you can say cure rate, that actually depends on how many patients can maintain their disease in remission for 5 years at least. So if the patient is not relapsing within 5 years, then the chances of him or her relapsing are less, though relapses can happen anytime. But this duration is what I think I consider.
Yes, sir. In that case, if do we consider the depth of or the durable remission more, or the duration of remission more important in the patients?
Now, both, like depth of
Both.
remission in DLBCL, we consider by doing either you do interim PET and the end of treatment PET. That is the way how actually we define the remission status. And if you are achieving very good metabolic response on PET based, and then that is the depth of response. And obviously, duration of response correlates to some extent with depth of response. If patients are achieving early response, early interim PET is showing good response, then the chances of that remaining in remission is probably higher than those who are not achieving early or interim PET negativity. So that is actually how we can see the depth, and that may correlate with the duration of remission.
Yeah, hi, Dr. Naveen. So this is Pawan
Yes.
here. So when we see chemotherapy means the standard before the CAR T cell therapy, so it was easier to counsel the patient.
Yes,
If
sir.
the disease is chemosensitive, they are going to do better as compared to chemorefractory disease. Means I'm talking about salvage chemotherapy. So, in the CAR T cell therapy, when we are advising CAR T cell therapy or counsel the patient about the durability of the response and the initial responses, CAR T cell therapy, most of the time we try to harvest, get the uh, so we first we try to get the lymphocyte harvest done, and then after that, usually some bridging therapy is given. So in my opinion, the response to this therapy also may be the determining factor. If the disease burden is, so this data is very clear. If the disease burden is less, so these are the patients who are going to do better even with CAR T cell therapy. Plus, if suppose we have molecular signatures available, that also may help in doing. Like I remember my last patient just 2 months back. So it was very refractory TP53 DLBCL. So we somehow we could harvest the cells. Lymphocyte count was also low. So and these, but we could not infuse because the disease was very rapidly progressive, and nothing worked for him. So this patient could not reach up to the infusion. So these are the patients like we can predict, because if highly chemorefractory disease, these are the ones who are not going to do even with CAR T cell. But yes, this can be tried for these patients.
Thank you, sir.
So, Dr. Naveen, we know from a lot of trial data that patients who are primary refractory do worse than patients who have some sensitivity to chemotherapy. That data is quite clear in many of the subgroup analysis of various trials. So that is definitely something that pictures when we counsel our patients about what to expect, or the families for that matter, from the CAR-T response. And I think this question that you asked is especially relevant. It's a very good question because, uh, like I was mentioning earlier, that in the beginning, when we used to counsel our patients, or when patients read online that CAR T cell does wonders, a lot of that data is coming from, the axicell lysocell. But the Indian data is still new, is still early, and the numbers are not necessarily similar. We still have to look at bigger numbers to be able to say if the responses are entirely corroborating. So, in the beginning, I used to counsel as per the Western data, but as we have more and more data from Immunil and ImmunoAct, I now tend to counsel patients as per the latest updates they have given of, overall response rates of about 40 to 45% at about a year. So.
That was really enlightening. Thank you. And now moving to patient selection. So on paper, trial style selection is more straightforward. So with disease progression after at least two prior lines, ECOG performance status 0 to 2, no severe organ dysfunction, no active CNS involvement, and no uncontrolled infections. But the practical question is, in real world, we can't put all these criteria for all the patients. So which one of these criteria do we find the most need to relax in real life? And what compensatory safeguards do we put in? Whether we have to relax the performance status, organ function, or prayer lines, which is the one which we find the most needed to be relaxed.
So you are asking regarding CAR T cell therapy, Dr. Naveen?
Yes, sir.
Yeah.
Regarding
Ca-
during patient selection, which of these
yeah.
criteria we need to relax, sir, most? I mean, in your experience.
Yeah, actually, but one of the important criteria is that relapse is, if you are going by NCCN guidelines, whether the relapse is will before 12 months or after 12 months. So that is the one of the points which we have to first see. And obviously, most of the trials, they have excluded CNS involvement. So that again becomes important point, because we can't take a patient had involvement of CNS. Major organ dysfunction again will matter, because a patient with severe nephrotoxicity, hepatotoxicity, or any organ dysfunction will obviously be may not be that good candidate for that. And a good performance status obviously will do better, because there are many challenges even after CAR T cell therapy, and patients should be able to tolerate, should have enough organ function to tolerate these complications. So I think, and obviously, infection again plays a major role. Whether it's a transplant or it's a CAR T cell therapy, risk of infections are definitely there. And these patients post CAR T cell therapy, they will have B cell lymphopenia. So definitely, risk of infections will increase further. So all these, whatever, like a fit candidate with disease will obviously be preferred over a patient who is having multiple comorbidities, or who is not fit for that aggressive treatment. But again, saying that transplant compared to CAR T cell therapy, patients with CAR T cell therapy, we can consider even slightly more comorbid patients compared to that what we can consider in transplant. That's what I think we can proceed with.
Yes, sir. In to add, sir, in our institute, when we do CAR T cell therapy, when people in patients come with, say, for example, diffuse large B cell lymphoma, most of the times they have GI involvement and they have liver involvement, and the most thing we found need to relax is the organ function. Some of the times they'll have liver involvement. That
Yeah.
in our experience, that was there.
Again, extramedullary involvement, the chances of achieving remission after CAR T cell may be slightly less than those who don't have extramedullary involvement or extra lymphatic involvement, like a patient is having bone involvement or gut involvement. I don't think whether they will do better with those who do not have these involvements.
Yes.
Yeah, Dr. Pavan, Dr. Tejasmi.
Pavan sir, would you like to take the question?
Tejasmi, you can answer.
Sure. In my practice, I think quite similarly, if there's severe organ dysfunction, we tend to not take up a patient who's severely compromised in terms of their organ function unless there is disease involvement. And rightly said earlier that if there's extramedullary involvement, the chances of response are less. But considering that if this is one of the only options for the patient, we go ahead if the organ dysfunction is because of the disease. Otherwise, if the fitness is not so good, we don't go ahead with, we don't necessarily offer this to the patients. Second thing I'd like to mention is that uncontrolled infections. We've had a couple of patients with tuberculosis who were detected around the same time when we had to do their CAR-T. And in those patients, we first started them on ATT, ensured that they had received ATT for 2 to 3 weeks, and only then took them up for the CAR-T. And they did well. There was no issue with the tuberculosis management after that. So yes, definitely, uncontrolled infections, we have to check for that. And severe organ dysfunction, if it's not because of the disease, then that could be a hindrance in taking the patient up for CAR-T. So yeah, fitness is very important.
Yeah. One more thing is that patients actually we can't give too much time. Also, is also a crucial part, as Dr.
Yes.
Pavan's told, that if there is delay in getting the this CAR T cell prepared, by that time the patient may relapse. So that time also has to be considered, that how long it's going to get the CAR T cell and how you can maintain the remission by that time. So that factor should also be taken into account.
Thank you, sir. And the next is another concern is what if the patient has CNS involvement at the time of CAR T consideration? So since the most of the trials had excluded patients with CNS involvement, but in real world, many patients we have CNS involvement. So there is a small retrospective data from US Lymphoma CAR T Consortium where they had 300 patients, where 17 out of them had CNS involvement, and in them they had infused 15 patients. 10 had CNS resolution, but 5 had persistent CNS disease. So ICANS rates were comparable in both these groups, but the 6 months EFS is numerically worse in the patients who had CNS involvement. So the implied conclusion was like CNS involvement was not an automatic disqualifier, but the expectations for the survival rates were relatively less. So if my question to the panelists, what is the minimum CNS control or disease control or involvement you had in your practice before CAR T cell infusion? Have you infused anyone with CNS disease with CNS disease?
I'll take this first.
Yeah,
I have not treated anyone with CAR T cell therapy in an active CNS disease. No.
yeah, no idea, no personal idea. So
Personally.
yeah. But theoretically, as Dr. Tejaswin told earlier, that if you don't have any option and if CNS positivity is there with the disease, then ultimately you have to treat him with this or that way. Then, after explaining the family and patient everything, pros and cons, it being a last option can be considered.
Yeah, Pavan here. So based on the means trial data, we can see also that, but it is not a contraindication that
Yes.
it doesn't work for CNS involvement. Yes, we try and control the disease as far as possible by intracervical therapies or maybe radiation or whatever treatment is possible or the patient is eligible or patient can take. So try to control the CNS disease as far as possible before taking them. But yes, it can be given.
Thank you. And the next is, and there is this always a question. So is there an age limit? So is 70 a hard cutoff for CAR T? So there is one slide. It's an of a multi-center retrospective analysis of 172 patients, and 109 patients were younger than 70, and 63 were 70 years or older. So when they compared the non-relapse mortality and the overall survival, both the p-values were completely non-significant. So the question to the panel is, what is your take on a 75, hypothetical 75-year-old with no comorbidities? What factors do you consider before labeling the patient fit or unfit for CAR T?
So again, I think it would be better to see the organ functions, and if pulmonary or cardiac function is okay or reasonably good, these patients can be given because uh, when the cardiac reserve is not there and the cardiac and pulmonary reserve is not there, so the CRS or ICANS, these was mainly CRS can be fatal in these patients. So we have to careful about that, and otherwise I think up to 70 years should not be a problem. Like similarly, in a similar way, what we do in autologous transplant, 60 is not the only means the biological age that should not be considered as the cutoff value for uh, not taking these patients, because we in our routine practice also we have done by sometimes we do reduce the doses of conditioning, and we still take patients up to 65 years. So similarly, in CAR T cell therapy, also up to 70 years or maybe 75 also can be there if there is good organ function.
Yeah, age I don't think will be only criteria. If comorbidities are less, patient is otherwise active, then can be considered.
Yeah, definitely. It's the fitness that matters. Age, in this case, is hardly a criteria. If the organ functions are good, if the patient can tolerate the side effects of CAR-T well, I think they should be offered CAR-T. And I think it's far easier to perform a CAR-T in an elderly patient than to make them go through beam. So the fitness for CAR-T, I think, is usually not as stringent as I would say sometimes for tolerating beam. So
Yeah.
comes down to fitness more than age.
Thank you. And this is real, yes. Managing toxicity, uh, I'd like to share a small experience of a small cohort. We had a 35 patient cohort with cellular therapy, which we presented at ESMO Asia last time. So we found age was the only significant factor for CRS in this small 35 patient cohort. And not organ, I mean, age was the only one, and not the performance status, comorbidities, or organ reserve. But this is a small study, but uh, we mostly look at functional metrics rather than just age alone. And one more pre-infusion variable that needs highlight, it is recent bendamustine exposure. So why does this matter? So there has been an emerging real-world data suggesting that recent bendamustine treatment, especially in the weeks just before apheresis, can negatively impact T cell collection and product fitness. Some centers now try to space out bendamustine and other intensive therapy as well by 3 to 4 weeks before apheresis planning. This isn't a hard rule, but it is worth being aware of. So my question to the panel is, does your center adjust bridging or apheresis timing based on recent bendamustine, or do you proceed as usual? Because literature has conflicting evidence. There are some articles which says that bendamustine is really T cell toxic and to avoid, and some studies say it is not. So how does your center adjust bridging?
Yeah, so bendamustine usually, yes, it is definitely lymphotoxic. So means we have to follow that. It's very important. So because it's not only about the collection, means lymphopenia and poor collection of uh, T cells. But there is other reason is that they are not functionally. Means cytotoxicity data is also there that these are not. Uh, Functionally also these lymphocytes or the CAR lymphocytes, they are not very much functional in uh, fighting against the lymphoma cells. So ideally, yes, as far as some guidelines are also framed, but based on that, it's better to, means if it is possible, or we can wait for apheresis uh, by giving, or if the suppose disease is progressive, we can try some other salvage regimen. But yes, there's ideally the delay should be followed.
Thank you, sir.
In my practice, I avoid using bendamustine as a bridging therapy. And because I think there is considerable data that the again collection as well as the function in the later post infusion will be a problem in patients who have received bendamustine recently, and ideally 9 months, preferably up to 12 months gap is best, but definitely not as a bridging. I do not use it.
Yeah, same. So it should be avoided as much as possible, and we should go by that literature that yeah, it is lymphotoxic.
Thank you. And CAR-T has expanded beyond BCL ALL and DLBCL. So two other indications have been emerged. So first is indolent lymphomas, mainly follicular lymphoma, but with a higher bar, where it is given when there are two failed lines of therapy and a shorter progression-free interval, that is POD of less than 24 months. And in second, mantle cell lymphoma with at least one failed line, with typically a BTKI inhibitor, BTKI exposure. So the question for the panelists, in your center, what is the most common indication outside of B-cell ALL and DLBCL where you have used CAR T-cell therapy? And if we are using for indolent lymphoma, what do we consider as an edge for the eligibility, considering the eligibility? Which indication, which tips the scale to make the patient eligible?
Yeah,
Yeah,
Neeraj.
other indication I would say that it is the indolent lymphomas, especially the follicular lymphoma, who have failed multiple lines of therapy, and the POD is less than 24 months. So these are the means next common indication I would say, and uh, mostly, but some for mantle cell lymphoma. So far, I have not done for any mantle cell lymphoma, but other is the indolent lymphoma. Yes.
Okay, sir.
And
Yeah.
the other factor is, the indolent lymphomas, they usually means the diagnosis age is higher, and by the time they become refractory or fail 2 3 lines, their age progresses. So they are usually uh, in the higher age group as compared to DLBCL or other lymphomas.
My one question is like we have data for DLBCL where early transplant, early failure should go for transplant, for CAR T cell rather than transplant. So in these lymphomas, indolent lymphomas or mantle cell lymphoma, do we have any guidelines where transplant should be avoided and CAR T cell should be given priority over transplant auto? Dr. Pavan, any such?
Yeah, I think the same reasoning, because in indolent lymphomas we have other treatment options. Like for follicular lymphoma, if you see,
Yeah.
we can still manage these patients and try to get some durable remission. The problem is, by the time they become refractory to 2 3 lines of therapy, their age progresses and they may not be eligible for autologous transplant. So in
Age.
these situation, CAR T cell would be better option, and in fact, that's why the recommendations are also there to give it for patients who have failed multiple lines of therapy, or if they have rapid progression, in a similar way. Sometimes some follicular lymphoma we see the POD 20 is less than 24 months.
Mm. Or maybe many patients who have failed auto transplant, they are definitely a candidate for CAR T.
Yes, or if we have tried auto and they failed, so these will be another group of patients.
Yeah.
How about you, ma'am? Have you tried
I've
any?
only given CAR T to patients with large B-cell lymphoma, and not yet given to any of the indolent lymphomas, because I think a lot of good therapies exist for indolent lymphomas. But definitely, any patient who is refractory to therapy, there are no further therapy options, would be a good candidate for CAR T in such a setting.
Thank you.
Dr. Naveen sir, Dr. Vishnu has also joined as a panelist for this panel discussion. You can also ask him.
Okay.
Dr. Vishnu, you can answer yourself.
Yeah,
Actually,
yeah. Okay. So
yeah.
actually, I have personal experience of using CAR T cell therapy. So I am just a listener.
Now all questions will go to Dr. Vishnu.
So, revisiting a table, this is a quick reminder of why CAR T interest is high in relapsed ALL. So, it is in historical data where from 1989 and 1990, where it shows transplant at CR2 has only 22 to 43 percentage of leukemia-free survival, depending on risk category and study. So this sets up a rationale for CAR-T as a definitive therapy or as a bridge to transplant. So my question to the panelists, in current practice, do you see CAR-T in B-cell ALL as a definitive therapy or more often as a bridge to transplant to achieve MRD negativity to allogenic transplantation?
Yeah, Dr. Vishnu.
I feel it should be a bridge to transplant. So definitive treatment is still allogenic transplant, especially in like high risk ALL or when we are considering patient in CR2.
I think there is no right answer to this question as of now. We are still in the process of getting answer to this question because whatever trials have been done, they have concluded CAR T as a definitive treatment, and they did not include stem cell transplant after CAR T. But definitely, what I think is we still need further more data to answer this question.
Yes, yes. As a one single case experience we had a patient of B-cell ALL who is Philadelphia-like, which I'll be presenting later. I have two cases. So the patient had achieved MRD negativity at day 30, but unfortunately when he presented at around day 55, he had full blasts in his blood, right? Around 55% blasts in his peripheral blood. So when we tried to assess the cause, we did an bone marrow biopsy and redid a flow cytometry. When we saw the CD19 expression in the blasts were completely gone. So possibly the cells might have gone CD19 escape. So we retrospectively thought if we had transplanted the patient when he had achieved MRD negativity, maybe we in this context we might have used CAR T better as a bridge rather than a definitive therapy. We had that confusion, but we tried to find data, but there was not a single data which says otherwise or says supports one approach.
Yeah, we still need data to answer this
Yeah.
question whether all patients who are undergoing CAR T and achieving remission should go for transplant, because many of these patients we will be able to avoid the toxicity of transplant, allo transplant, in those patients unnecessarily who are going to achieve or remain in long term remission. So subjecting all patients with CAR T cell in remission
Yes.
to allogenic transplant will be too much of toxicity. So we
Yes,
still
sir.
need an answer to this question.
Yes, sir. So, touching back on the same question, similar question, does the target antigen level matter? So, there is a retrospective study of 166 patients looking at CD19 expression by flow cytometry in B-cell ALL before giving CAR T-cell therapy. So, the bar chart compares remission and non-remission rates in CD19 high blasts versus CD19 dim or negative dim blasts. The p-value is 0.14 and not significant. So the question for the panel is, if we see CD19 dim on pre-CAR T-cell flow cytometry, does that change the counseling to the patient or it does not? And yes, sir.
We can
So we need to see.
explain, yeah, we can explain it to the patient that the responses will not be as far as great as, but still it doesn't mean that it should be denied. So dim expression, yes, it can be done, and as far as this data is concerned, though the p value is not so significant, but still means I would try to counsel the patient in this way, that yes, it can be tried, but the outcome will be less as compared to the CD19 bright or normal expression.
How about you, ma'am?
I agree with that, that CAR-T can still be done, even at dim expression. CAR-T, if indicated, we should go ahead with it. It's only in the patients who don't have CD19, where there's like a tumor escape. Maybe they've received some other therapy prior to that because of which it has happened. Those cases, of course, we have to reconsider, but otherwise we can give it.
Okay, thank you. I have two cases which we did CAR T cell therapy for whom we did. So, first case is a 41-year-old gentleman with uncontrolled diabetes as comorbidity with relapsed refractory Philadelphia like B-cell ALL with FLT3, Icaros, JAK1, and anti-5C2 mutations. He had two prior lines, a BFM 2002 induction and inotuzumab with mini CVD. First relapse was 6 months after BFM, and second relapse was earlier, 3 months after inotuzumab. So we planned him for anti-CD19 CAR T, did salvage with Rs, hypercVAD, venetoclax, and tofacitinib because he was not able to afford ruxolitinib, but tofacitinib is a pan-JAK inhibitor we gave. And then we did lymphodepletion with fludarabine and cyclophosphamide. On the day of CAR T cell infusion, his TLC was 500 and he had persistent cytopenias. So the question for the panel at this point is, at the TLC of 500 with active cytopenias, do we give GCSF at the day of infusion or do we try and avoid it? Sir, Pawan sir.
On the day of infusion, we usually avoid this, and maybe means we usually start GCSF maybe after means day 2 or 3 onwards.
Okay.
In usual our practice.
I think on this day, of course, in the Indian setting, we have to consider infections, but I would give CRS as a more priority as a differential diagnosis and treat it from that point of view and avoid GCSF then. On the day of the infusion.
Yeah, if patient is otherwise asymptomatic, then I think we can wait. There should be no hurry in giving GCSF.
Yes. We also went ahead with that. We avoided GCSF for fear of giving another cytokine just
Yeah,
around infusion.
definitely. Yeah.
And next day post infusion, said patient had 102 fever and there were no localizing signs. So at this point, do we think of CRS more or infection more? So we and nonetheless we sent procalcitonin blood cultures and interleukin 6 levels. So we will if we do we wait or we'll give tocilizumab? And if we are giving tocilizumab, we'll be giving it at grade 1 when it is early, or we'll wait for higher grade and then we'll give. So it has two questions. So whether we'll give early tocilizumab, and if we are giving, at what grade we give.
Some people are giving prophylactically or just
Yes.
empirically, means at earlier phases. But I usually prefer giving it late unless there is some hemodynamic instability or like very high IL-6 levels. So these are the things which we consider in our practice. We try and delay it as far as possible.
Okay, sir.
Yeah. So since patient is having fever, antibiotics will obviously be the first line of treatment.
Yes, sir.
Along with that, tocilizumab, considering CRS, should also be included, because you can't differentiate based on anything, because all symptoms will match. Hypotension, everything may happen both in both sepsis and also in patients receiving having CRS. So differentiation will be difficult, but treatment
Yes.
should include both.
Okay. How
Yes,
about you,
I
ma'am?
think this is a very common clinical scenario. We cover with empirical antibiotics and along with that, decide to give tocilizumab, usually a single dose, stat dose, to see how the patient is tolerating and if the symptoms come down. And yeah, but CRS might be the more likely diagnosis, but we always side by side cover with antibiotics.
We did the same as well. We gave antibiotics and we gave tocilizumab as a 400 mg flat dose. So in practice, do you give 400 mg flat dose, or we'll give the full 8 mg per kilogram dose at this point?
We give as per weight.
Okay.
Yeah, full dose.
Sir, how about?
Yeah, mostly I usually give one vial, just 400 mg stat
Okay.
flat dose.
The next question is 8 to 10 hours after giving tocilizumab, the patient continued to have 102. Procalcitonin was low, and the culture, though the vial showed no culture medium showed no positivity, and there were no localizing signs. So we have given already toci. So I mean we gave at 400. So it's ideal to top it up to the full dose, or to add some second agent, say like dexamethasone. So the question for the panel would be, what would be ideal to complete the dose of
This
tocilizumab?
will be a difficult scenario, difficult clinical condition, so, so whether to decide about adding other agents like particularly steroid. So you can try giving a steroid, but in this situation, because procal and other thing, these are not the only
Yes,
markers which determines differentiate between sepsis and CRS, because all other signs of sepsis and CRS will be almost the same. Like if suppose patient develops hypotension and other things like tachycardia, all those things maybe means mimicking with the CRS and sepsis. So we have to be very careful about this. But in my opinion, yes, if the patient is not responding, persistent fever is there, and we think that it is not sepsis, yes, steroid should be given.
I think a repeat tocilizumab would not be a bad option, because at least two doses of tocilizumab and still patient is not responding, then we can say that he is not responding to tocilizumab. But one more dose can be considered, at least after 12 hours patient is still having fever or signs of CRS.
Right. I think it will entirely depend on the clinical scenario. How sick is the patient at that point? How rapidly is the patient deteriorating? Whether we want to add both or continue with one. So it is entirely going to be dependent on the patient's, developing clinical condition. So yes, I think either options is good. I would take a call based on the overall clinical picture.
So at our institute, we do solid organ CAR-T also as part of experimental therapies. So in those patients, we use high dose interleukin 2 for TIL, tumor infiltrating lymphocyte expansion.
Dr.
So
Naveen,
those, yes, sir.
we
Yes.
we kindly
Yeah, there
request
is
you
only
to
one
conclude
case.
the.
Yeah,
Please.
there is only one more case.
Thank you.
So thank you. In that case, we were afraid of getting the CRS. We got an experience of controlling the CRS early, leading to better prognosis. So we added dexamethasone. So, and by day two, the fever also subsided, and the patient had received 2 doses of dexamethasone and 1 dose of tocilizumab. So now that fever has subsided, but patient still being in the CRS territory, on day two, is it wise to add GCSF to hasten neutrophil recovery, or should I wait for a few more days to give GCSF? In short, the patient has just recovered. I mean, the CRS symptoms have just subsided, but the patient is still cytopenic.
I would still
And we,
like to wait
okay,
for GCSF. Yeah, because you have seen proven probably that it's CRS only.
yeah,
Then you can wait. I think.
okay.
Yeah, Dr. Pawan, Dr. Tejaswini, Dr. Vishnu.
In this scenario, are you saying that the hypotension, everything has resolved?
Yeah,
Yes,
Yeah,
yes.
then I would say wait.
yeah.
Yes.
There is one final case. So a 40-year-old man with no comorbidities, follicular lymphoma grade 3. He was stage 2 at diagnosis, but he was referred because of multiple, he had relapsed post 9 lines of therapy and had bulky disease at referral with the mediastinal mass of 15 centimeter and cervical nodes of 10 centimeter each. So this we took as an indication and we performed anti-CD19 CAR-T and we used radiation bridging. So we used fludarabine cyclophosphamide for lymphodepletion after CAR-T infusion. By day 45, when we did a PET-CT, the metabolic response was seen across all sites. LDH was well below within the normal range, and but there was one residual occipital node, which was 2 by 1.5 centimeter. But previously, before therapy, it was 5 by 3 centimeter. So it's small now, but it's still PET away. So do we observe this node or do we intervene? If we intervene, what modality? So we looked up for literature. It said it had very mixed opinions. Some asked to observe, some asked to irradiate the lymph node, and some asked to give systemic therapy. So what would be the ideal? What the panel thinks would be ideal?
If it's a single lymph node, you can wait,
Wait.
or at least you can do a biopsy and see what it is. So I think both options are there, and but if the PET avid, how much is the avidity compared to previous avidity of the lymph nodes? Avidity is too much, then a biopsy becomes first option to see what this avidity is due to, whether it's a lymphoma, high grade again, or something else.
Okay. The avidity was this avidity and the size had reduced. Sir. 5 centimeter it was previously 5 by 3. It was 2 by 1.1. So
But why this lymph node is persistent,
yes,
single, and FDG avid? You are saying it's avid.
yes, sir.
So how much is the avidity? That will also will matter. If it's too much avid, high avidity, then it should be maybe it's some infection or something else. You still need to prove it.
Would
Yes.
you call it like a
So
dual 4 or 5 or maybe lesser, although
It
it's
was dual
if
4.
three or less, then we can wait. If more
5?
than three, then biopsy should be done, four or
Yeah.
five.
It was 4, sir, actually.
Yeah.
That is why we if it was 3 or we thought
Yeah,
of waiting.
wait.
But yes.
Yeah, so in this situation, yeah, obviously, if it is there, so we have to be on close monitoring. And I think the other point in this slide, which you have mentioned, is about the CAR T persistence, you know.
Persistence.
So
Yes.
there is obviously for academic interest, you can do that CAR T cell persistence, but you know, even if it is losing or there is exhaustion of CAR T cells, then obviously we cannot do anything at this moment. But for a clinically for managing this patient ideally, if we, I agree with Dr. Sanjeev and Tejashwini that we have to do the biopsy, and if suppose any evidence of residual disease is there, they should be put on some kind of maintenance therapy because it's a single node only. Means
Okay.
that the intervention which can be done.
Yes, definitely biopsy
Uh,
should be done at this point before going
The
in.
patient asked he'll come, he wants to wait for a month and then he'll get the biopsy done. He insisted that he gets the biopsy done. Thank you. Thank you. This was a very enlightening discussion, and I had got so many points which I can apply for my real world practice as well. And thank you, all the panelists. And I'll hand back to the organizers
Thank you,
for
Dr. Naveen. Very
audience
Thank
nicely
you.
questions.
Thank
conducted.
you, everyone.
Thank
Very
you.
nicely conducted.
Thank you, Dr.
Good evening.
Thank you.
Thank
Thank
you,
you, sir.
Dr.
Thank you.
Naveen, for this lucid moderation, and also our esteemed panelists who shared their insights and valuable experience in CAR T cell therapy in the management of lymphoma. Thank you very much for joining. Now, for the next session, I invite Dr. Amrita Ramaswamy for the session on aplastic anemia. She's a principal consultant, Department of Hematology at Max.
Can you hear me?
Yeah, you're audible.
Yeah, so I'll just share screen. See, my network is not really good, so I'm not going to share my video. And I want to keep it very brief because my laptop just hung up and I'm doing it on my phone. So, and it's at, I think, 8:50. So I just want to be very brief. And the topic given to me is aplastic anemia. Um, just a minute, let me share screen. No, sorry. Top share. My phone has a whole lot of prescriptions and documents. So just a minute. Okay. Can you see my screen?
No,
Can you
ma'am.
see my
No,
screen?
no, ma'am.
No. It says unsupported document type. I don't know for what. Just a minute. um, Dr. Avriti, I'm really having trouble sharing my screen. It's just not happening on my phone.
So can we try from our...
I'll have to quickly share the presentation with you. Let me just try once more, please. Screen. So generally, I don't have a problem even on my phone, but I think so I'll quickly email it to the tech team and maybe they can share it from their end.
Okay.
I'm just going to leave the meeting, Dr. Avriti. I'll just email it to them and then I'll join back.
It's okay, ma'am. Ma'am, if it is, ma'am, since you're outside, it is difficult for you to join. It's okay, ma'am. We can, if it's okay, we can close the session and we can sometime again have a
So
discussion
that's
on
not an
aplastic
issue.
anemia with you.
That's not an issue. I actually texted you because I knew I was anticipating this problem. So
Yeah. Yes, ma'am, I can
I'll
understand.
just excuse myself and I'm sorry the slide sharing didn't happen and I'm sorry about the slides. So you can wind up. I'll just pass it on over to the organizers, Dr. Avriti. My sincere apology, okay?
No, no, ma'am, it's absolutely fine. Thank you very much, ma'am, for sparing your time, and I'm really sorry for the issues you had to face. Um, Thank you, everyone, for joining the session, and I'm very grateful to all the esteemed faculty who joined the sessions and enlightened us with the latest updates on the various issues like leukemias, lymphomas, hemophilias, uh, and a wonderful session on CAR T cell therapy with a good moderation by Dr. Naveen and our esteemed panelists. So I thank all the academic partners, Roche, Concord, BSV, Genova, Zydus, Takeda, Reddy, Strand, and AbbVie for their partnership, and Cancer Research and Statistic Foundation for their ADs. Thank you very much, everyone, for joining. Good night, everyone.
Thank you, Ram. Textbook